I'm going to ask, we'll just kick off with our first talk. It's my real pleasure to introduce friend and colleague, Professor Doug Thorburn, Professor of Hepatology, very senior transplant clinician from the Royal Free Hospital and University College London.
Thanks very much for the introduction, and thanks very much to Helen and AMMF for the invitation to speak at this meeting today, and also for the very powerful experiences that have been shared this morning. It's really grounding to hear such moving experiences described. So I'm going to talk about liver transplantation in the UK for cholangiocarcinoma. This is just to provide a very brief overview of where we are with liver transplantation in the UK. We do 900 to 1,000 liver transplants, and up until just shortly before the pandemic, there had been quite a substantial growth in the amount of transplant activity over the 10 years preceding that. But in the first year of the pandemic, there was about a 20% reduction in the number of transplants undertaken. And while we've seen a recovery in transplant activity since then, over the last few years, most of the recovery in transplant activity has been through the use of these so-called cardiac death donor livers. And these are more marginal grafts where the outcomes, while similar, it's more challenging to use these grafts to deliver favourable outcomes. And despite that reduction in activity, an increase in the waiting list size over the same period, lengthening in waiting times, there's been no associated increase in waiting list mortality, which seems to mean that we're transplanting the right people, so we're meeting the needs of the population that are waiting for a transplant. But there's also good evidence of utility in terms of the outcomes of the patients that are transplanted. So these are patients that are transplanted elective liver transplant. So these are patients with chronic liver disease. And 1 year outcomes, you can see, are quite tightly clustered across the 7 centres, around 95, 96% at 1 year. And then at 5 years, it's around 85%. So there's really good evidence of excellent utility. So that's maximising the outcomes for the donor organs that we're supplied with. So it's a balance between meeting the needs of the population who need a transplant and also our duty to maximise the benefit that we accrue from the donor organs that we're provided. And it's important to remember these concepts when we consider transplant for cholangiocarcinoma. So this was the early phases of transplant during the exploratory time of liver transplantation in the 90s. And there's plenty of data that's similar to this. This is data from Leeds over a 10-year period, 100 patients that were considered for surgical treatment, and of whom 12 were transplanted. You can see that the outcomes of the patients who didn't have a transplant were very unfavourable, so a 13% 1-year survival. And while there was no difference in survival between the patients who had a liver transplant or had a resection, the overall survival at 5 years was 20%. So while for that individual patient that was a better outcome than receiving no surgical treatment, it didn't meet the predetermined utility and futility measure that we have, which is anticipating a greater than 50% survival 5 years after transplantation. So liver transplantation, there was really a moratorium for liver transplantation or intentional liver transplantation for cholangiocarcinoma from the mid to late 90s. But we've continued to transplant patients with cholangiocarcinoma since then, and this is data that was put together from 6 of the 7 UK transplant centres, looking at patients who'd had liver transplants and found on their explant to have an incidental cholangiocarcinoma. So these are people that were not recognised to have a cholangiocarcinoma at the time they were added to the list or at the period, during the period they were being monitored on the list. The majority of them were either intrahepatic or perihilar. And what's interesting is that actually the outcomes of the patients with the intrahepatic cholangiocarcinoma were quite favourable, 57% 5-year survival. And those patients that had early stage disease T1 tumours, had good survival at 80% at 5 years. It was still, even in this incidental group, it was still by far the minority of patients that fell into that category of early disease. So it does seem that there may be, based on this evidence, some subsets of patients that could benefit from transplant, even though that was not a group of patients where we were intentionally transplanting for this. The transformation of transplantation as a concept for patients with cholangiocarcinoma came through the work of the Mayo Clinic in Rochester, Minnesota, and University of Nebraska, who really championed this. And it was based on the observation that treatment with radiotherapy and chemotherapy, followed by brachytherapy, improved longevity in patients with cholangiocarcinoma. And they built, rather than just transplanting patients with no neoadjuvant or adjuvant therapy, they piloted and championed this neoadjuvant pathway. And there's been an evolution in their selection criteria. So you can see it's a very small subset of patients with a small hilar. So these are patients with perihilar cholangiocarcinoma, a single tumor that's less than 3 centimeters with no metastases. And they've even expanded the criteria to the point now that they do not need to have a histological confirmed diagnosis at the point that they are brought into the program for transplantation. So if they've got a mass that would be considered to be consistent with the diagnosis, they're allowed to be taken forward to transplantation. And after they've had the neoadjuvant therapy, there's a staging surgical examination followed by further chemotherapy up until the time of transplantation. And the experience from this, from the Mayo, has built over the subsequent decades. And in 2020, they published this paper where they described the 376 patients that were enrolled in this pathway. And you can see over half of them had PSC. While all the patients at the point that they were taken forward to the pathway seemed to fulfill the entry criteria that I've described, there was a significant dropout rate at various points. And in the end, only 63% of the patients were transplanted. And in terms of the type of transplant they had, most of them were with deceased donors, some of them were with live donor transplants. And you can see the outcomes. So these are the outcomes from the point of entry into the pathway, 5 and 10 years, and this is from the point of transplantation. And you can see the really favorable outcomes that they describe with a 70% 5-year outcomes after transplantation. So really encouraging. And this is looking at those patients with PSC and perihilar cholangio versus the patients with sporadic or de novo perihilar cholangio. And you can see that the patients with PSC are in blue had more favorable outcomes from the point of registration into the pathway, at the point of transplantation, and also had approximately half the rate of recurrence at 22% versus 45% compared to those patients who had sporadic or de novo cholangiocarcinoma. And most of the recurrences occurred within the first couple of years. So based on this data and evidence that was accruing internationally, because a number of centres in Western Europe and even Dublin and Ireland have taken, and in other North American centres have taken on liver transplant for perihilar cholangiocarcinoma. And we've, in the UK, been revisiting the role of liver transplantation for oncological indications. And in addition to cholangiocarcinoma, we've been looking at colorectal liver metastases in patients with metastases from liver metastases from neuroendocrine tumours. And we've developed these as pilot evaluations. So these are areas where there's international evidence of acceptable outcomes. And it's really to see whether we can replicate that data. So it's not a clinical trial. It's really a service evaluation to see whether in an NHS context, and within part of a national programme, we can deliver these outcomes. And there's good examples of where we've done this, and we've then accepted these as indications now that are become routine indications for transplantation. The process of this involves somebody coming up with the idea, bringing it for discussion. If the liver advisory group, which is an NHSBT group with representatives of all the centres and the lay members and patient groups are supportive, then an implementation group is established to develop the pathway and the SOP for the process, and determine what outcome measures are of importance and what would be meant by futility within the pilot, such that the pilot would be closed, and also the monitoring and oversight of the pathway. And for cholangiocarcinoma, which has been taken down this route, we have to give thanks to Nigel Heaton and more recently Raj Prasad for their role in taking this forward. I was the chair of the Liver Advisory Group when this indication was taken through. And we're now at the point where, at least for a subset of patients, we are able to offer liver transplantation. I'll say more in a second. The implementation group had involvement of a whole range of stakeholders, including AMMF and PSC support, the specialist societies, NHS England, and the NHS England proton beam commissioning team. The two groups of patients that were identified as being suitable for this pilot are those with intrahepatic cholangio in the very early category, and those with perihilar cholangiocarcinoma with a background of PSC. What we mean by very early is that they have a single tumour that's less than 2 centimetres in size. They've to have background of chronic liver disease. They've got to be irresectable, deemed irresectable by the HPB-MDT, and that could be because of the function of the liver or the position of the tumour. And they've got to be pure cholangiocarcinoma, not mixed cholangio-HCC. And this is based on this international data collaboration that was led out of Toronto, where they looked at the outcomes of patients who'd been transplanted with intrahepatic cholangio that fulfilled the very early criteria that I've described. And what they showed was at 5 years, the outcomes were favourable, 65%, 70% survival for those with very early, and also acceptable rates of recurrence compared to those patients that did not conform to the criteria that I've described. And so that pilot is now open, and if a patient is identified through the MDT, the diagnosis is made, they have staging investigations, a biopsy to prove the diagnosis, they're taken through the transplant MDT, listed. The intention is to transplant them within 3 months of registration, and if they're not transplanted within those 3 months, they're re-evaluated and restaged to see that they remain within the criteria. There's no stipulation about neoadjuvant or adjuvant treatment, and there's no requirement for downstaging, and in fact, there's no route into this through downstaging patients such that they confer to they fit into the criteria described. In terms of hilar cholangiocarcinoma, on the background of PSC, it's really similar to the Mayo protocol. The difference is that we require a confirmed diagnosis, and Simon's already spoken a little about how a diagnosis is made, and patients that have had prior treatments are excluded. If they've got metastases, intrahepatic or outside the liver, then they're excluded also. This I won't go over, but is again, our requirement is to make the diagnosis through a combination of either EUS or ERCP. And again, it's not stipulated what what approach is taken, for the same reasons Simon said, the important thing is a diagnosis is confirmed and there's histological evidence of cholangiocarcinoma. The thing that's innovative about this pathway is that in the UK we don't have brachytherapy, or we don't have access to brachytherapy. So the recommendation of the group, including oncologists and experts from a radiotherapy background, were that in this pathway we should use proton beam therapy for neoadjuvant treatment. And the thing that's really innovative is that about this is, while there is some accruing evidence of the use of proton beam therapy in irresectable cholangiocarcinoma, this is the first approach to using PBT within a liver transplant pathway, and hence some of the challenges that we've encountered in getting this program open, because it's not a commissioned indication for proton beam therapy. There's 2 centres at the Christie and at UCLH that deliver this, and while NHS England have supported the use of it within this pathway, it's necessitated taking it forward as a single-arm study, looking particularly at the feasibility and tolerability of proton beam therapy, and that's created delays. So after the neoadjuvant therapy has been administered, again, similar to the Mayo protocol, there's restaging. If there's no evidence of spread, then they are counselled listed. And again, the aim is to transplant them within 3 months. And if not transplanted within 3 months, further restaging at 3 months. And this just is to demonstrate, again, the complexity of this pathway and the intensity of the imaging and the monitoring of the patients that are required. The average patient on the transplant waiting list who doesn't have a cancer indication is probably having an ultrasound every 6 months, say. The patients with a cancer indication are probably having CT scans on a 3-monthly basis. So you can see it's really complex. And this is the pathway itself. The patients are coming from the hepatologists in secondary care, from HPB units. They've got to go through the cancer MDT. They've got to be deemed irresectable. Then they've got to be seen by the transplant MDT and determined to be suitable for transplantation. And then there's decisions about, are they medically fit for transplant? Over and above, are they oncologically suited to transplant? And then there'll be those patients who are outside criteria or lack histology. And it's over here, it's this part of the pathway that is EMPHATIC, the single-arm clinical trial of PBT. And none of the other treatments, liver transplant or the chemotherapy that are being administered, are the sort of trial treatments in this pathway. It's purely around the feasibility and tolerability and the toxicity of proton beam therapy. And that's being assessed by the proportion of patients that are having grade 3 adverse events, and also those patients that are successfully coming through the pathway and making it onto the list and being transplanted, and also their survival after 1 year. So just where we are now, as I've mentioned, the intrahepatic cholangiocarcinoma pilot is open. It's been open for between 1 year and 18 months. So far, 1 patient has been registered, and that 1 patient was transplanted within the 3-month window. As I've mentioned, the perihilar cholangiocarcinoma pathway isn't open yet. I've talked about this commissioning evaluation and the need to take that through as a clinical trial. All the administrative information that's required to submit for ethics is now complete. I expect, if not by the end of this week, beginning of next week, the ethics submission will go in, and then it will be the usual timescales for opening clinical trials in the 2 PBT centres before we're in a position to open the programme for these patients. So I think the remaining challenges are those of ensuring equity of access. So how do we communicate this to all the HPB centres nationally so that this is a consideration when patients are being seen and evaluated in the across the country and across the 4 nations, because our objective is to offer this to patients across all of the UK. But there's also an expectation management. I hope I've demonstrated the complexity of the pathway, so it's really challenging to deliver this, and it's different to the experience in the Mayo, where everything is on their doorstep, and they can. We're talking about patients from all across the country going to 2 centres to have their neoadjuvant therapy, and as a result, there's a challenge around the coordination and the delivery of these pathways. But we're very optimistic with the enthusiasm that we have to take this through. That we can evaluate the 30 patients that are planned, and hopefully in the process of that, if we can demonstrate that the outcomes are favourable, the NHS England will then allow us to, will commission this for the ongoing care and the routine management of patients with cholangiocarcinoma. Thanks very much.